Hello, everybody.
Hey, Alexander, very, very warm welcome to this Geeks course. I'm David Tate. We never met in person or even virtually, so very nice to meet you here. But we were introduced via a common friend,
Yeah,
and it is my understanding that you're here to give us a presentation about Hemopill over about 15 to 20 minutes. So we're very, very grateful for that. And we would just ask you, because we're ready now for your presentation, for you to introduce yourself and for you to take away your presentation. And afterwards, hopefully, we can ask you a couple of things and discuss a little bit.
yeah, certainly. So thanks a lot for giving me the opportunity to present this. And I see you're quite still busy working, but you were talking about therapy. So my topic is more or less diagnosis, and I was asked to present our data on the Hemopill, which is, I think, a new device that is not so familiar with for all of you. So maybe some words about myself. I'm head and professor of gastroenterology here at the University of Würzburg. I've been doing endoscopy, I don't know, since decades meanwhile. And yeah, I think we start right away and then focus more on the question. I will start right away, not with thank you, but with this. And of course, I have to mention that I'm working as a consultant for the company that is having this device that I would talk about, the Hemopill device. So let's start right away. I think what we all know, and there's nothing to worth mention about that. If you see this in a patient, um, then probably you don't need any hemopill because you can be quite certain that the patient was some hematine in the stomach that he or she was vomiting. And of course, if you see red blood, that this is no discussion that you need any further device to look whether there is still some active bleeding in the stomach, because this is certainly signs of active bleeding. And what's also worth mentioning is, and we know this also from the guidelines, that even a picture like that, sometimes if you have severe upper bleeding, this can also, or even if you have that, that can also be sometimes related to severe upper bleeding. But we are talking more about those where it's not so obvious bleeding. And that's the patient that shows up in the emergency setting, and patient complains that maybe he had some black stool, or maybe some vomiting, but not proven vomiting of blood. And then the question is whether they do an endoscopy. And I think we're all aware of that quote of an unknown source that when you do endoscopy, patient is either too fit or too unfit to be scheduled for an emergency endoscopy. And there has been a lot of debate about the timing of an endoscopy. And usually you differentiate between 6 hours, within 6 hours, which is emergent, within 12 hours, urgent, early, or maybe you can also postpone the procedure and wait until patient shows up on a Friday until Monday. Or maybe you don't have to do it at all, or next week, or whatsoever. So if you look to the guidelines of the ESGE, you see that's also something very interesting. And sometimes you need a lot of arguments with your colleagues that they say, when the patient is bleeding, you should do an emergency endoscopy. No, this is not recommended because outcome might be even worse for non-variceal bleeding. We're talking about non-variceal bleeding. And even an urgent endoscopy is not really recommended, since compared to early endoscopy, the outcomes are not improved. So at the end, ESGE recommends that following hemodynamic resuscitation early, that means within 24 hours, upper GI endoscopy should be performed. So all the rest you can delete. The only thing that remains is an early endoscopy within 24 hours. However, the question is 24 hours a rather short period of time, or maybe a rather long period of time? I think we have to little bit more focus on the individual patient, because there is also another data was published several years ago, but I think it's still relevant, that if you look for those patients that are at a high risk of a Glasgow-Blatchford score above or equal to 12, you should really scope these patients within 12 or 13 hours, because thereby, if you do that, you reduce mortality. And in this study, mortality was 0 versus 44%. So I think you have to some sort of differentiate among all those patients. So 24 hours might be for some too long, but for others, maybe also too short. And if the patient has a high risk, probably you should not wait 24 hours. You should maybe wait at least until the next morning to scope these patients. So when and whom should we scope? And then let's go back to the Glasgow-Blatchford score. If there is below 0, okay, we all agree about that. No endoscopy is necessary. However, if it's above 11, so high-risk patient, maybe it's worth to do an endoscopy within 12 hours rather than 24 hours as recommended in the ESG guidelines. And then we have this large group of patients, most patients, they have an intermediate risk. And then the question is, should you do this within 24 hours? Or should you rather postpone the endoscopy, maybe if the patient shows up on Friday, and then wait until next Monday? Because delay certainly would save resources. And then, however, we need better information rather than only the clinical impression scores. So we should focus on this group with an intermediate risk, which are most patients that have a Glasgow-Blatchford score of 2 to 11. And for these patients, it might make sense to use an additional tool to help you guiding the timing of the endoscopy. And one of these tools might be the Hemopill, which is a rather simple device, more or less. You just swallow a sort of a photometric capsule that measures hemoglobin, nothing else. And as soon as it detects hemoglobin, there will be a peak, and that will be visualized on that receiver, and it's called a so-called of a hemoglobin index. And as soon as it's in the red range, that means the index is above 1. It means that there is liquid blood or hematine. So it does not have to be an active bleeding, but also a very clear sign of a previous bleeding. And that's a positive finding. And then you may discuss whether these patients should be scoped earlier or not. So what are the first data on the Hemopill? The first clinical data was just more or less a feasibility study because here 30 patients with symptoms of acute upper GI, they were included and 27 were eligible. And then they did an endoscopy and then they found that blood or hematine was present in 10 of these 27 patients. And all those patients where no blood was detected, they were correctively identified using that device as non-bleeders, so ruled out as no active bleeding source. Then there was a next study, and here patients were retrospectively analyzed, and a little bit more studies, some with an upper GI bleeding, some with small bowel bleeding, and some also for exclusion of rebleeding, so more or less more just some cases, but not really very good data. And technical success was given. And here the capsule was positive in almost 6%. And endoscopy showed bleeding in almost the same patient. So there was a good correlation. But this is more or less just showing what we would expect already, that if you see blood in endoscopy or if the patient is vomiting blood, then the capsule is positive. But then the next question is, how would that guide us for timing of patients, as mentioned before, which I think is still a not fully cleared situation. So here we just performed our prospective randomized, not randomized, but prospective study, multicentric study that was just recently published in Endoscopy. And here patients that showed up with signs of an upper GI bleeding, they were stratified in those that were positive in the Hemopill and those that were negative in the Hemopill. And those that were positive, we all scoped them. And then, but those that were negative, we looked whether they occurred complications within the next 2 to 3 days. If there was such complications, those were also early scoped. And if not, then the endoscopy was postponed to 2 or sometimes even 4 days after admission, first admission in the emergency department. And then all patients, they underwent a telephonic follow-up after 30 days. So these were the two groups. There was one group of 32 patients that was capsule positive, and then there was another group of 41 patients that was capsule negative. And you can see there was not such a big difference among those groups. Maybe the risk was a little bit higher in those that were capsule positive with respect to bleeding risk, measured also on the blood urea. There were also the INR was a little bit higher in these patients, but from all the other data, these were fairly comparable. So what are the results of that study? So a little bit more than 80 patients were screened, and there were some excluded because at the beginning we had some concerns with respect to pacemakers because there's some for the transmission of the capsule data to the receiver. And there was also one patient where we had some concerns because he complained about dysphagia. This were the rest 73 patients, and they were, as mentioned, divided into the capsule positive and the capsule negative group. Both groups, they received PPI when they showed up in the emergency room. And the capsule negative, they were treated with a PPI per an orally treated PPI for the until they had their endoscopy. So these are the results. The capsule positive group, you could see that endoscopy was performed within 12 hours, and almost all of them active bleeding or potential sources of bleedings were detected, and only in 5% there was no source of bleeding. In contrast to those that were scoped within 2 or 4 days, no source of bleeding were detected in almost half of the patient, and the others was no active bleeding as a forest tree or some erosions or some non-actively bleeding angiodysplasias or Cameron lesions. Only 2 patients, they had to be scoped earlier because there were developed some hypotension, and we wanted to rule out active bleeding. And therefore they were scoped earlier, but there was no active bleeding. One of them had a cardiac carcinoma, and the other one a forest 3 ulcer in the duodenum. So these were the endpoints. Avoided emergency endoscopy on an intention to diagnose basis was quite good. So we had really a very reliable tool to rule out that if the patient is negative on the Hemopill, there is no necessity to scope this patient earlier. So you can really wait maybe until the next Monday if the patient shows up on Friday. And the most interesting thing was the negative predictive value to active upper GI bleeding that was 100%. So you can be rather certain if the capsule is negative, then there is no active bleeding. And then, of course, you might conclude that maybe for those that are positive, maybe it makes sense not to wait until 24 hours, maybe scope them earlier. We don't know yet. That has to be tested for further studies. But what you can also see is if the Hemopill is negative, then PPI therapy alone is enough. And then you can delay the endoscopy, and probably admission is not really necessary. So this would then be the next steps on this study, and we also would like to discuss your ideas or whatever you think about the results. So maybe we should focus on those that have a suspected GI bleeding with a Glasgow-Blatchford score at least of 2, and then look for the Hemopill. If it's positive, then maybe scope them on the next morning maybe within 24 hours, but preferably maybe even earlier. And if the negative is Hemopill is negative, then maybe we can further treat this patient on an outpatient basis. So give them a PPI morning and evening, and then schedule them for an ambulant EGD within maybe 72 hours or whatsoever. Of course, we need further analysis with respect to costs. And of course, also with respect to safety, we still don't know whether there might be one patient that might have a severe recurrent bleeding that is not detected by Hemopill, but based on our rather early data, we can conclude that a negative predictive value was 100% so far. Well, that's it already. Thanks a lot. And I'm really looking forward to your questions and further input on the capsule, the Hemopill. Thank you.
Yeah, thank you so much. This I think is a fantastic concept. I think it's a fantastic idea. It's a really big unmet need. I think that's really clear, and that's why we wanted to showcase it. And I want to congratulate you for how hard that you're pushing forward with this and for the data that you're generating. I don't know if the faculty, John, anyone in the room has questions. I mean, of course, I'll start. I think that you would agree probably that more evidence is required before we can, that we solidly recommend this, but that the evidence till now is encouraging. Is that how you would badge it? Yeah.
And as mentioned, I would also like to see your input, because it's also, we also have these different countries with different approaches on how to treat this patient, on also resources. And I think that's also relevant if you want to take the next steps, because like in my country, if you treat the patients on an outpatient basis, you don't get any money. So reimbursement is only available if you keep the patient in the hospital. That was also the reason why we had some problems recruiting patients,
Yeah, I think that's a super important point. So the seventh edition of our symposium, which is in October, will focus on value for money in all aspects of endoscopy, including therapeutic endoscopy, but also focused on the basics and GI bleeding. And what you've just said, I think, is the crux of it. And I had someone whispering my ear during this your talk that in Belgium, this probably wouldn't be something that would go forward easily because of the reimbursement issues around it. But that when we have these discussions, John, I'm interested in your point of view from the UK. It's not quite the same there, I know that, but it is not really acceptable, is it, that we are sitting here having a conversation about something we know would benefit patients. We also know, if we zoom out on the healthcare system, that if we avoid admission for a certain percentage of patients based on this and that this is safe, that those patients will cost the healthcare system in total way less money, because they're not sitting in hospital for 3 days and having all of the things that and I don't know, but in Belgium, certainly just the inpatient bed per day, nothing else, no therapy, 1,000 euros a day. Right. So already, if you say even that this pill costs 1,000 euros, the 3-day admission versus the one pill, and I know it doesn't cost 1,000 euros, I'm just saying something. So that zoomed out approach suggests, and plus the fact that the patient doesn't need to be in hospital, isn't at risk of healthcare acquired infections, isn't at risk of venous thromboembolism because they're not in the hospital, etc. So all those downstream effects that no one looks at, because the lens is what's the reimbursement for this and that. So I think we really have to engage the healthcare payers in this discussion. John, do you agree with that?
Yeah, absolutely, David. I mean, triage is really important here, and I think it does help with the triage in terms of timing. I think it possibly even more impact in patients so we have a group of patients who've got normal blood tests, but someone writes down that they've had a hematemesis or it's in the clotting notes. And it seems that that patient doesn't leave the healthcare system until they have an endoscopy, even though there's no evidence of a GI bleed, until we do a negative endoscopy. And I'm of the belief, I tried to push at our place, that if they had a Blatchford of less than 1, they don't need an endoscopy at all. They just need some PPI. We don't need to do endoscopy. But people are so risk adverse that they still get their endoscopy. So I would like this to be used to almost help triage people who don't need an endoscopy at all. So Blatchford less than 1, and maybe people who have a negative pill count don't need an endoscopy. You might want to give them some PPI if they're symptomatic, but otherwise they don't need an endoscopy. But it's a leap of faith, and we are fighting a system which is risk averse. And for all the reasons you said, David, in terms of healthcare costs, and it's opportunistic costs. Because if you're scoping one person who doesn't need it, you're denying someone else the opportunity to have that procedure. So I think it will help fit in the algorithm. And I think we need some really big adult conversations about who we're really going to scope and not going to scope. And it's the not going to scope is where we need the discussion, really.
I mean, you've gone one step further, haven't you, John? I'm interested in your opinion on that, Alex, under that. John has gone one step further and said, not because in your study and everything you're talking about, the patient does get an endoscopy. It's just the timing that changes. Whereas John has gone for the golden goose of, yeah, they never need an endoscopy. But I don't know what your opinion is on this. I'm not sure that this tool can easily be used to make that decision.
I hope so. I would hope so. Of course, we don't have enough data so far, but based on our previous study, my conclusion would be now if the patient is negative on Hemopill, just give them a PPI and send them back home. And then, of course, then the question is whether scope them at all or scope them maybe on a later time. But I fully agree that we scope way too much these patients that come to our ORs, and as John said, that somebody mentioned, well, there might have been some blood somewhere somehow, and then you have sort of that pressure, and this is certainly something that that's a dilemma, and we should really discuss about that. But we need more data, and I would also be keen for more patient data with that Hemopill, or whether it's any other device or whatsoever. But I think we need an additional tool to better guidance us through that dilemma.
Okay. Maria, yeah.
Yeah, I have a question about, I don't know if it was in your, I don't think it was in your protocol, but do you have any experience with risk, like the rebleeding after treatment? So there is a patient, you treat the bleeding, and then a few days after it's going fine, but there is hemoglobin drop, and again, like Elena, is there a role? Because in this kind of patient, it's probable that we're risk-scoping it, and then we find nothing. Is there a role in this?
That's a very, very good question, what you're asking. And I fully agree that also that's something to monitor these patients more better and closely. And we were also thinking about using that Hemopill device that not only measure it for the period of 2 hours, but also measure a period of maybe 2 months or 1 month. And to detect early rebleeding. That's also something I was thinking about. But then, of course, we did it once in 2 patients, honestly speaking, and we have that Hemopill that had a measure schedule for 1 month. But then you have the problem that sometimes you have some small peaks, some small positive peaks, and the patient realizes and sees it, and then he or she gets extremely nervous. And that's something that we should focus on only. So maybe we should focus also on having another threshold for the measurement device for those that we monitor rebleeding, as you said, in contrast to those where we want to detect bleeding. But that's a very interesting aspect, and we should further focus on that.
Yeah, I just had another quick question, but maybe I saw it wrong in the results slide. The group that was Hemopill negative, there was 1 or 2 patients that were hypertensive and did need an urgent endoscopy. The pill was negative in those, or they were hypertensive before the pill was done?
No, the pill was negative, and then hypertension was detected while we were sort of following them up. And but the reason was not related really to bleeding. Okay. So at least that bleeding, then we scoped them earlier, but we could not detect any bleeding source. So it's still 100% true negative.
Okay, thank you.
I mean, I think from my point of view, John, please come in. I feel that is the clinically relevant parameter. If we're going to use this as a screening tool in the ED, which I think is where I see the unmet need for this. Those patients can then go home, can be scoped at some point, in my view, is still what needs to happen. Then the negative predictive value needs to stay not at 100%, I think, because no tool that we use clinically has a negative predictive value. And you definitely will encounter cases as you increase the numbers, but very high, right? What do you think, John?
Yeah, no, I agree. Absolutely. I mean, like everything in medicine, David, we're applying science to an art where we use multiple parameters, and it comes back to what we said really early in the day, that at the end of the day, we are making decisions based on the information in front of us, whether that be in treatment or in this case in triage, and whether to go ahead with the procedure. I think the more information you have, the more confidence you've got that your decision is going to be correct. And this, I think, will form part of that triage and decision-making process.
I've got two colleagues from other hospitals here, so I don't want to just monopolize a discussion for Ghent. John and I have spoken, but I don't know, Lynn or Pitian, you want to make a comment about your hospital and whether you think that this is an unmet need there as well?
I mean, I think it would be a great tool for those cases indeed that come in the weekend or in the night. I see the value, but on a Monday morning where you have a list and you can scope the patient, I think we will do that endoscopy anyway. So I don't see the need there for now, but indeed for those cases or where it's unclear if there was an actual bleeding, definitely, yeah.
I mean, what you've said there is quite interesting, and maybe this is the last comment we have, that in the night or out of hours, I mean, John, I liked your presentation very much, and I liked the part, the very memorable slides you had of the sleepy endoscopist and of the person waking up from their bed, like completely awake now that you've told me about this GIB and having to wait. I mean, this could be a thing, though. Do this pill, and if it's negative, don't call me. You agree?
Be perfect, yeah.
Well, that's what I was also thinking, because it's quite variable on who is in the emergency room. If you get called for stuff that you think, why are you actually calling me? Because this is absolutely not urgent, because they have no idea about the score or whatever. And sometimes you have people coming in that you would think this person would need an endoscopy and they don't call. So I think as an extra safeguard, I think it would be a good thing for that they can admit they don't need to call you because it's negative, but the patient needs admission for anything else, but they don't call you to have the urgent endoscopy. But if the patient is well and it's negative, that they can indeed send the patient home. So I think it's an extra triage.
To speak to what you're saying, I found it quite striking, Alexander, that in your study, the table comparing the pill and negative and pill positive, that the Glasgow-Blatchford score was comparable between the two groups, because that means we cannot clinically, even with the best scoring system, which, to be honest, I'm asking them to apply in the ED before they're calling me, it still doesn't discriminate between those patients. So I see that as high value.
Yeah, I fully agree, and that was also what I mentioned, that we have in the vast majority is just between these 2 and 11 points where we some sort of really don't know what to do. But I fully agree, we need an additional tool. Maybe one short comment. What I think also might be useful, I don't know whether how it's in your country, but here we have very small hospitals that do not have 24/7 endoscopy available, and then sometimes these patients, they transfer to my hospital with a helicopter, at night for nothing. And
but then it's big cost saving. Yeah.
That's definitely not cost saving, Yeah.
Helen, you had a comment?
I'm sorry if I missed it. Just a practical question. How does it practically work? You swallow the capsule and you get lifetime data, or in terms of how applicable it is to an emergency department?
It's completely simple. It's so you just patient swallows the capsule and then you press the bottom of the receiver and you can see a wave, and it's either below or up 1. And if it's more than 1, then it's sign of bleeding. It's absolutely simple.
What these data are not blinded to the patients. That's correct.
The patient did not know that it has to be above 1 or 0. The patient did not know, but that was just analyzed by the nurses or some the medical students that took care of that. Yeah.
So you did not see an increase of anxiety of...
No.
I do think that is a very important point, because the reader, as I understand it, the reader is on the patient or near the patient, or is that not the case?
No, it's his patient, and as I said, we had some anxiety, as I mentioned before, when we used it for monitoring, because then the patient has to be sort of trained that look at the receiver, and once you see it's positive, then call us. For the monitoring over a longer period, that might be something to be concerned. for the short term within 20 minutes, I don't think so. No.
Perfect. All right. Well, I think I really want to thank you very much for joining us. And thank you very much for your what I see as quite groundbreaking work with this product. Keep on going, and if we can be of any help to you in the future with it, we're very interested. So thank you very much.
Thank you very much. My pleasure joining you. Bye-bye.
Bye.
Bye.